So I am going to also share a high impact case that we have all shared here within my department in infectious diseases. It's definitely a big multidisciplinary approach. Um, it's a patient with necrotizing pneumonia and lung abscess. Next slide. And one thing that I would highlight, pretty different, and I know this is probably going to be, contrary to what we had already talked since the beginning of the talk, which is the use of the test in immunocompromised patients. This is actually an immunocompetent patient. And this is someone that we are currently taking care of. My partner, Dr. Al-Sam, and I'll give credits to him, that we are all took care of this patient. And we are, we were definitely very surprised by this case, but I will definitely highlight the importance of the test, potentially even for immunocompetent patients towards the end of the presentation. This is a gentleman, a 44-year-old gentleman, probably known to our group and the other infectious disease group in town for previously treated tuberculosis. He actually was treated twice due to concern of reactivation, persistent lung findings over a period of months to years, and recurrent admissions for respiratory concerns, usually cough. Um, he had actually had been diagnosed with cavitary pneumonia and had undergone multiple testing for other causes of cavitary disease, including invasive fungal infections. Even in the last 2 or 3 years ago, he was actually treated for aspergillosis with voriconazole after a test had suggested that this could be the etiology. However, he presented also early this summer due to persistent worsening of symptoms and radiological findings. At that point, my very astute partner considered that there could be Burkholderia as a possible diagnosis, but also other possibilities. So we actually coordinated a new bronchoscopy with our pulmonary partners. And this is, CT scan from about a year ago, or less than a year ago, probably 6 months prior to the patient presenting to our institution. At that time, he had a bronchoscopy. You know, this is like a very delicious case for infectious diseases and pulmonary. I mean, this is clearly a cavitary disease with intercavitary lesion. So we're thinking about, could this be some form of fungus ball? This patient at that time underwent bronchoscopy with negative Coulter's pathology, which I will talk about in briefly. Did not really reveal anything significant or anything that will help us in the differential. The patient then presents now with, as you can see, a more thickened cavity in the right upper lobe. Next slide. I think, at this point, we always will think in someone who had TB that this could still be TB. That's kind of always the notion that we always have. But it was interesting because after multiple testing, traditional testing, molecular testing, and pathology, we did not came to a specific conclusion. It's very likely, of course, that this is just a chronic cavity, and this is just can superimpose infection. The pathology did reveal acute inflammation with discriminated pneumocytes and hemorrhage. There was no granulomatous changes or malignancy. The AFB stains and fungal stains were negative. Next slide. As you can see, this is our latest bronchoscopy, mixed respiratory flora. There was definitely growth of Pseudomonas fulva. Patient had already been treated empirically. This was definitely not believed to be, this was actually in culture, of course, and this was not believed to be the actual pathogen, but the histoantigen in BAL was 0.21, pretty low for what we typically will see. In terms of fungal testing, fungal markers, all the rest of markers return negative, including histoantigen and in serum. The rapid test of the film array actually returned with H influenza, and the patient was actually treated with antibiotics previously for this. But now the new pathology is showing actually abscess with necroinflammatory debris. This is actually the result of the spectrum, the plasma test. As you can see, we're seeing a mixture of, this is an example of the report that you would get. Microbes with pathogenic potential, most of what you see probably there is organisms that we would probably deem respiratory organisms and not necessarily pathogenic. But then we organized and arranged for the send out of Focus BAL. This is probably one of the most high impact kits we have so far. We started using the Focus BAL earlier this year, and we detected Streptobacillus moniliformis. I'm sure some of us also call it. I'm sure it's also called, not me, but everybody calls it rat fever out there in the world. We also detected respiratory flora and other organisms like H. flu with a potential for disease. So doing further inquiry, this is not something I think we were really expecting from the history. Typically we would think this would be a superimposed, cavitary process with, fungal infection or a microbacterial process. But looking back and talking to the patient, actually, we found that the patient had ran over some dead rats with his lawnmower. So this is, a very unique case in, of Streptobacillus moniliformis pneumonia. Usually we will see more likely, in rat bite fever, usually is more likely skin and soft tissue. So this was, this continues to be a case that is actually being prepared for further presentations down the line because it's still in process. We're still caring for this patient. And actually the patient with discussions with cardiothoracic surgery later underwent right thoracotomy. So our diagnosis was, chronic cavitary pneumonia with new abscess and superimposed Streptobacillus moniliformis infection.